Welcome, Dr. Sarah. Thanks very much for joining us.
Thank you, Patrick. Thanks for having me.
Can we start with a bit of your personal backstory? Where did you grow up? Where were you born? Where did you grow up? And why? What drew you to medicine?
Sure. So I was born in Sydney. I spent my primary school years in Sydney and then moved down to the Southern Highlands, where I went to school down there with my two brothers. I then took a year off and did a bit of travel, spent some time in Europe with a friend, and then went to Peru and did some work over there. All the while knowing that I definitely wanted to be a doctor. Always wanted to be a doctor, probably just because I like people, and I'm a bit of a nerd and I love science. So it's a beautiful combination of both science and people. Then I went off to Sydney Uni and gave it a go and loved it from the very first minute. So it just kind of felt natural, and that's where I ended up here.
Yeah. Well, tell me about that. You always knew you wanted to be a doctor. When do you remember when that started to really clarify?
Look, it's funny. I've always been interested in why, and I think that's that love of science. Why do things happen? How do we fix it when it's broken? I love people, and I also had a beautiful GP growing up. So my GP was just phenomenal. She's still practicing now, and she diagnosed my mum with my pregnancy when she came back from her trip very unwell with what she thought was gastro. It was actually me. And then she was there when I sort of had my first pregnancy test. And that beautiful ability to be across someone's whole life experience while still using your science brain. And that's just felt really exactly what I was meant to be doing.
Yeah, I think that's one of the things we forget about GPs. Certainly in the old days, they were part of the family, weren't they?
Yeah, absolutely. Yeah.
And
And
is that you trying to keep that going? Is that part of the philosophy in the clinic?
look, sadly, it's not actually what part of this clinic is about. And I am really sad about that because we are not doing cradle to grave medicine here. It's the clinic is developed because the system that we work in Medicare at the moment just doesn't allow for slow medicine, long consults to be part of just general practice, I feel. It's a bit of an overgeneralization, definitely it can be. There's some amazing doctors doing amazing work in general practice in women's health. But I found for me, being able to give the time to the consults that I think that it needed, I wasn't able to do it properly in general practice. So I'm still practicing that sort of continuity of care with my women within a women's health context. So I also get to do a little bit of looking after some people's mothers and their daughters and seeing how their sort of that genetic component of maybe Polycystic Ovary Syndrome, or which is now PMOS, endometriosis, even fertility issues trace through generations. So there is still a little bit of that generational care.
What about the fact that you're entirely devoted to women? What was your strategy and philosophy behind that?
Yeah. Look, I honestly think part of it is being a woman myself, having all my friends, my experience over the years as women talking to me, the women in my life, talking to me about their experiences, their periods, their pain, their mental health, their fertility journeys, and how that has been treated in the medical industry. So all the times that they've either been dismissed, told they're normal, overdiagnosed and sent straight to specialists, all of that kind of flavoured how I felt about women's health, and then also my own personal experience. So I was diagnosed with Polycystic Ovary Syndrome when I was quite young, which is now called PMOS. It's going to be tricky in this podcast. And I remember, so I was in medical school and had access to great care. I had a brain that understood physiology and I had all the data there, but still I would find myself going down these deep spirals, Google and Reddit, of fertility and will I ever have babies and what's the best supplements to take. And I did. I used to order stuff online and think, what do I do? Will I ever be able to have a baby? I also have endometriosis, and that was diagnosed after all my babies, actually, when in my late 30s. And it is quite, it's not shocking because I haven't had an awful time of it. It's definitely not a sad story, but it is a story that shows that through my teens, when I was starting my periods, I had awful pain. And I look back on it now and I was like, oh, yeah, that actually is exactly, if someone came in to see me, I would 100% say, oh, you've got endometriosis, or let's look for it at least. But I didn't think about it. I was on contraception for many years. I had all my children, and it was only later when I came off my contraception, wasn't pregnant anymore, did my pain come back, and I was like, oh, what is this? Like, this is so odd. What's happening? I went to see a phenomenal gynecologist, a colleague of mine, and he said, oh, you've got endometriosis. It's like, I don't have endo. Of course I don't have endo. I'd know if I had endo. I'm a women's health doctor. I do this every
I'm a
day.
doctor.
And he was doing a surgery for another reason. So he was like, well, I'll just have a look where I'm there. And he was like, yeah, full of it. You've got endo. And so the fact that I can miss my own endo, the fact that I didn't have years of pain, that I was dismissed or anything like that, a phenomenal GP, but it just shows that it is such an issue that needs addressing.
So many women's issues along those lines are sort of they're not ignored, but a lot of women are told that that's normal. That's what you've got to put up because that's part of being a woman.
Yeah.
And having read some of your stuff, though, I see that can be a big mistake, not getting diagnosed, and the time in there can be quite costly, right?
Yeah.
You've got what should women be thinking and to avoid that situation?
Yeah, so you just mentioned the cost. So the cost of missing these things. So it's not so much dismissal, because dismissal is sort of an active thing. And yes, there have been women dismissed, and sure, there haven't been some great doctors. But on the whole, GPs, doctors are excellent, intelligent, caring, well-meaning people that are trying to do the best for their patient in front of them. The fact that it's been under-recognised and under-treated, under-heard is more of a systemic problem. But the cost is more than just, oh, you got a delayed diagnosis. So we talk about this delay in diagnosis of 7 to 8 years for endometriosis. The cost actually gets its sticky little fingers into every aspect of a woman's life. So the obvious ones medically, so you got your physical cost. So with endometriosis, if you don't get early treatment, you can get adhesions, you can get chronic pain because it changes your nerve fibres and your pain pathways in your spine and your brain. It can impact your fertility. It's an inflammatory disease as well, so we know a lot more about inflammation now actually leading into other chronic conditions. Polycystic Ovary Syndrome, or PMOS, that is a metabolic condition at its heart. And if you don't treat it appropriately metabolically, rather than just throwing the pill at it, then we're going to set up women for chronic metabolic conditions, which will affect their health, but also financially for the Medicare system. That's another story. Preconception, another area that is missed, just because women don't know that it's a thing, and doctors might not be trained very well in it. But if you get preconception right, you're improving the life of something that isn't even here yet. So it doesn't even exist, this human, and we can still improve its health. So that's the physical cost. Financially, so there are so many women that have left their jobs, so many women that can't work because of pain, so many appointments that are being paid out of pocket to look for answers that they're not getting their answers. And then so much money spent online, like me, buying supplements and programs to try and fix things that really a bit of education and a bit of time with a doctor could have prevented. There's relationship costs. There's Medicare costs, really. If we put the money back at the forefront in the prevention, in the long medicine, slow medicine, we would be saving many, many, many dollars later down the track, because those women aren't going to be needing chronic health management later if they can get it right. Got estrogen and osteoporosis and fertility, and look, so many things in terms of cost. And then the saddest one is the mental health cost. So either the most tragic being if you're not recognised to have a hormonal depression, whether it's PMDD or whether it's a perinatal depression of menopause or perimenopause, that can lose lives. We can have suicide due to that, but also the loss of trust in yourself as a woman. If you think that something's wrong, you're constantly told it's not, it's normal. you think there's something wrong with you, you're not coping, you're either weak or it's your personality that just doesn't cope. And eventually you just doubt yourself. You don't believe in what your own experience is. Too much cost.
That's really extraordinary. When you're really opening my eyes here, because I think that we've trusted the system too much. Is that fair? I think most people just go along, but what you're saying is particularly women need to be taking control and being positive and proactive.
Oh, look, could probably get a bit political now, and I try not to, but it's this condition, a situation where we trust our government to provide a system of care that works for everybody. And it's immensely hard. I cannot imagine being the health minister or anything like that. But the focus is wrong. The focus is on money. The focus is on preventing ED admissions, which cost the government a lot of money. But the focus has drifted over years. So originally, when Medicare was set up in the early 80s, it actually remunerated slow medicine just as well as it did the quick medicine, exactly as it should. And for many reasons, the freeze, the different changes in governments, all of that has resulted in the system that we have now. People don't understand how the system works. A lot of people don't even understand what rebates are or how Medicare works or the concept of bulk billing. What they get taught is the headlines from the news: free healthcare for all you need is your Medicare card, just come and tap it, it's all good. And so they're not explained that to get long care or, a longer appointment, slow medicine, they don't know that they need it, one. And I'll get on to education in the system and at home in a second. But when they go and get it, they're assuming that the government is paying for it, that they're delivering it. But sadly, as a GP, and without getting into the money side of it, because all GPs are very well remunerated for what they do, but the GP that sees 5 people in an hour for maybe a script, maybe a referral, a cold, a stubbed toe, and an infection on a cut, that GP will earn over a third more than the GP that sees 2 women's health consults for half an hour each.
Wow.
The medicine
just doesn't make sense, does it?
It just doesn't make sense, right? The medicine is equally difficult, but arguably the medicine to do women's health well requires a bit of extra training, a bit of investment, both time and money, from that doctor to be better at it, and emotional time. So to sit with a woman and explore all of her, the difficult times that she's had, to educate, as opposed to just write a script, send off a referral. It takes more time. I love it, absolutely, but it's more draining. So those doctors, male and female, will end up leaving public bulk billing practices, should I say, or stay there and start adding a gap to account for that that 35% difference, and to make up for the time they're going and doing extra training, and emotionally the time that they often stay back later, send off reviews, or I send off a summary to every patient, because that's the most important part for me, is you'll forget 80% of what I tell you in a consult. And we've got studies to say the 20% that you do remember, you'll remember half of that incorrectly. So, sending off a summary with links and education like that, it takes time. And it's just not set up in that system that way.
I get that. And so your approach is much more holistic. Okay, so that's the wellness part as well?
Yeah. What's
wellness? Define wellness for us.
Gosh, we've just been doing some new rebranding at the moment, and wellness it's really stuck with us. Wellness for me is living well through education and evidence. So understanding your body physically, in terms of structurally, hormonally, physiologically, understanding your own risk, everything about you, and then using evidence, what we know, with not just what we've thought to know, what sounds good, and living well that way. So that for me is wellness, and that's why we've kept the name in the word in our name, because there's a bit of a trend of wellness, big wellness, has a bit of a different flavour. We all have the same outcome. We all just want people to be well, right? It's just the approach that we take. So here at Sydney Women's Wellness, we focus on time. All of our appointments are quite long. Education, so it may be a bit overwhelming and a bit boring for some, but I go through flowcharts and I go through the cycle. We've written educational guides that we send off to patients, because I think if you figure it out once and for all how it's all happening, you don't have to keep coming back being like, why is that happening? Oh, okay. People understand their bodies will stop doubting their bodies or fearing their bodies, because without education, fear likes to sneak its little fingers in, and so does the wellness industry in a sense, like to monopolise on women who are looking for answers that they haven't been getting elsewhere and promise them to feel better. But they don't have to have the same rules and regulations we do, so they can make big claims. And then the last thing I kind of already touched on is that we document it and summarise it and send it to you so that you've got it. It's your plan, it's your something to go back onto, so that you don't have to be reliant on the health system. You've got it all there.
You're switching it around in a way too, aren't you? You're making it proactive instead of reactive all the time.
And that's not a novelty idea, novel idea in medicine. Like, we're all taught that in medical school. Prevention is key. Prevention. We've got the Red Book in the RSVGP, and lots of what we do in general practice is preventative: screening, doing blood tests, checking my height and weight and blood pressure. This is probably just using that same view and putting it to a way of practicing, not just individual items.
But you're also in a battle against a system which is really, structured around reaction, isn't it?
And I've kind of taken myself out of that battle. And it's a little bit selfish. It was self-preservation, really. To be able to practice this way, I had to set up a practice with long times, but the onus has now been put on the woman. So the woman that can afford to get the care, because it's all private, it's out of pocket, there is a rebate, but it's terrible. And also the women know that they need it. So the education gap, that knowledge gap, to know that a lot of women don't even know what perimenopause is. They definitely don't know what PMOS is. And preconception care, most women don't even know what to do when the two lines come up. They go, shit, I should go see a doctor. But they didn't realise, and then you ask them, are you on your prenatal vitamins? Are you immune to rubella? What's your iron levels like? Like, I don't know, how was I meant to know that? So the onus of the system failings has now been put on to the woman, to either afford it and to know about it.
Well, let's just explain to me one of the biggest areas, which is perimenopause and menopause, right? That's one of the areas that I think for most women, in my experience, it's like a gigantic mystery. It really, when you think about it, we're taught so little about that in comparison with the impact that it can have on people's lives, family lives as well. So what should we be doing? How are you approaching that with your patients?
Yeah, so perimenopause, spot on, is, look, the spotlight's coming onto it now, so it is getting much more recognition than it ever has. But as a time of life, it brings up a couple of issues. So it's normal. It's not a disease. Nothing is wrong with you. You get symptoms, you feel awful, but it's not a disease. So what do you do about it? Do you just suffer through it? It turns up in lots of different parts of your life. So bad sleep, sweats, ringing ears, period change, maybe no period change, maybe some hair loss. It's all very subtle and odd. So putting it together, if you've got no understanding, is difficult. It also comes and goes. So some months you're fine, some months you're not. It also happens at the most difficult time of your life. So your 40s and your 50s are peak career, peak kids, whether that's, pubertal teenagers who are going through just as much hormonal chaos as you are, or toddlers, because we are having our babies later. So some women are going through IVF, breastfeeding and then coming straight off into period change, hot flashes, and going, hold on, is this breastfeeding? Is this IVF? Is it what's going on? They've also got, these women tend to have older parents, so they're sort of split all their time between their kids, their partner, their job, their parents. There is no time on the list. They are number 728 on the list of things to do. They also were brought up in a time that their mums weren't talking about it. And if their mums are still around, some of those mums are saying, well, that wasn't a thing in my day, or I never had that. Now, the problem with that, and it's definitely not on that generation of women, it's not their fault because they were never given the language for it. Definitely if they went to the GP, they were never going to be given hormones. Their mums, even worse, they suffer through menopause probably. But also there's that retrospective versus prospective appreciation of symptoms. So if you write down your symptoms in the day, you track them like in the time, we know we've got studies that show they're much more different from looking back on them. So all these women who don't remember perimenopause for them or thought it was fine probably did actually have some terrible perimenopausal time symptoms. There is a lot of SSRI use, so antidepressants thrown at women in the 40s because it kind of makes sense, right? You've got stress and works hard and you've got a big mortgage and I feel crappy and my parents are unwell. Here's an SSRI. But really, that is all perimenopause. So it was there. It's not new. It's not this new condition that we've all caught. And it is a normal progression. And so with that, the trick with medicine is we like boxes and categories because that helps us study them, it helps us understand risk. But hormones, especially in women, female hormones, we are a continuum. It's just a gradual decline. Every woman is different. So it doesn't neatly fit into a 15-minute appointment where you go in and say, oh, hi, I've got tinnitus, burning tongue, my shoulder's a bit frozen, and I just don't feel right. That doesn't work for perimenopause. And it's no one's fault, it's just we just need to try and change it.
How do we need to change it?
We need to educate everyone. So the women are doing a pretty good job at educating themselves. It's all over social media. It is like I get patients coming and being like, I don't know, I was at drinks last night, someone said I had perimenopause to come and to see you, or there's a walking group in my suburb and all of them are my patients now because they go walking and they talk about their symptoms. So it's women talking about it. It's educating husbands and so they know to be like, look, I actually don't think you're going all right. Could it be perimenopause? Or if at least understanding it in the home environment. And it's workplaces, allowing for people to go and take an hour off to go and have a perimenopause consult. It's appreciation of the language around it, not pathologizing it, not making it into a condition, but just an appreciation that it's there. We don't need to educate our children, but we kind of, it's a sort of a point that comes up quite often with mums that come into my room saying they feel like they're terrible mums. They need to fix it. This is awful. My husband, he's a poor guy, he's having a really tough time with it. And the kids, I'm yelling at them all the time and I'm not very good at work. And it's all about how their perimenopause is affecting other people. When it comes to kids, I tell them the fact that they're even sitting here saying I'm worried about my kids makes them an excellent parent. So full stop, you're doing an excellent job. But also this intergenerational silence about symptoms and about perimenopause, it needs to change. So allowing your kids to see you struggling, yelling at them when they're not doing the right thing, but yes, it might be an overreaction, that gives them the language, the permission to understand in 30, 40 years' time when their sister, cousin, friend goes through it, they'll be like, perimenopause, I know all about that. Hopefully it won't be a thing because we'll all be treated and it's just, but if it is, we've got language around it now.
What about the hormone therapy? That's always seems so confusing to me. There are really strong views both sides about it, but I find it very confusing.
Yeah, look, it's really tricky because it all comes back really to one study, the WHI study, the Women's Health Initiative in 2002. And it was a flawed study to start with it was then sensationally ended because of this fear of risk. And then because of what they did in the media and the publications that they produced, the headlines were really alarming. So the headlines that that you'll hear about are hormones cause breast cancer, or estrogen causes breast cancer, and it increases your risk by 26%. So disregarding the fact that it was not the best study, and we've actually now gone back through the study and we use a lot of the data from that study for really positive things in hormonal therapy. But it shows a lot of the misinformation all comes down to our understanding of risk and fear, and how we can do that. So how I like to talk to my patients about it, I talk about ice cream, sharks, and marathon runners. If that's random.
Okay.
So risk, first off, we've got two ways of understanding risk. We've got absolute risk and relative risk. So for a marathon runner, if they're running a marathon, they have 5 times the chance of dying of a heart attack in that time of running. So that's the relative risk is awful. The absolute risk is 1 in 500,000 runners actually die from that heart attack. So if I tell you, if you go for a marathon, you're going to have a 5 times chance of dying, you're not doing the marathon. You shouldn't do the marathon anyway, they're awful. But if I'd said, look, there's an increase of 1 in 500,000 people, do you want to go and do it? You'd probably be like, yeah, it's fine. The other thing is, in those marathon runners, they actually have a 30% less chance of dying over their lifetime because they're running marathons. It's healthy. Also, the risk of dying is only in that marathon time. So if we put that to hormonal therapy, we're saying, so yeah, the relative risk is 26% increased risk. The absolute risk is 8 in 10,000, and it's only while you're using it, but it also has all these other benefits for your health. So we really need to take it as the full picture.
So women generally should be reassessing this situation, do you reckon?
Absolutely. So
Right.
personal risk assessment from a breast cancer risk point of view, again, I'm being boring and talking about education, understanding breast cancer risk, understanding what hormones do to breast cancer risk, because that study tainted all hormones. But the hormones in that study were synthetic. We tend to use, for the majority of women, body identical hormones now, and they do not have the same risk profile. We do have a fantastic study that has been released earlier this year. It's an observational study, so it's a different study to the WHI, but it's huge. It looked at over 850,000 Danish women. They've got a phenomenal health system where if you use their health system, your data belongs to the government. Kind of.
Okay. Yeah.
So we've got all of these women that they then looked back and tracked through this thing called all-cause mortality. So dying from any reason. They then looked at the women that never used hormonal therapy, those that used it for 5 years, and those that used it for 10 years and more. They looked at some other things as well, but generally when you're looking at those parameters, there was no increase in death or risk of dying in any of those women. So whether you used it for 5 years or used it for 10 years. So it then tells us we need to shift our focus to how do we live those years? Are we living them feeling well? Are we living them, in fear of dying early because we're using them, but we really need them to feel well? This data, really interestingly, does show that it might be beneficial for women to be on hormonal therapy, but it is an observational study. It doesn't take into consideration BMI, health literacy, smoking. So it's definitely not a study to say that it'll make you live longer, but it definitely tells us that as long as women are able to be on them, like prescribed them, they're safe.
Just as we're getting towards the end there, can I just draw a few of your general things together? The rush in our health system that you're trying to combat. How important is that? And then if you think just to general potential patients out there, what should they be thinking when in terms of telling their stories and demanding time to have their stories be heard?
Yeah, so look, the health system is the one that we have, and it is really good. We do get with great care through the system. What we need is for women to advocate for themselves. So if you feel like something's abnormal, if you feel like nothing has been explained to you, you deserve to seek that answer. You can ask again, you can ask someone else, you can keep asking. If you're keep asking and not getting anywhere, come to see us, we will listen. And if you can't educate through a doctor, try and educate yourself. There's amazing resources out there. Understanding your body is so much more important than just trying to look at solutions without understanding where the problem is.
Are you an optimist about the use of AI in your practice and into the future for healthcare?
Yeah, what would I say? Yeah, I am an optimist. I'm a apprehensive optimist because I'm terrified as to where it's going to go. I've just done a talk recently on AI in medicine to some young women. And when I asked AI itself about my view on AI, being that being human is still going to be just so important no matter how much AI can do, AI told me that it depends on who the human is, whether they're a good or bad human.
Gosh.
Yes, look, I love it for being able to get rid of all the stuff that doesn't need me. Doesn't need me to listen, doesn't need me to care, doesn't need me to just read those nuances, like the silence, that if you ask someone how they are and they take that brief moment. I love letting it do my notes, like writing my summaries. I love it helping me sort of get as much information to a point, but humans need to listen to humans. That's
Yeah.
where care comes from.
Which is the essence of your whole practice, really, isn't it?
Yeah.
That you're trying to bring the human back into the system. I,
Yeah.
I think I think that's a wonderful thing. Are you optimistic, in general terms, about the improvements in healthcare for women?
Yes, I am. No, I really am, because I think the more noise it's getting, change happens with noise. So as long as we keep making noise, we are 50% of the population. We are not a niche, so it's not pandering to the minority. It'll change. It's a shame
Yeah.
it hasn't yet, but it will.
And just finally, about taking control of their own healthcare, what should patients, should women be looking at in selecting healthcare? What are the sort of important things to keep in mind?
Yeah, so get your advice from a doctor or a sort of a dietitian or someone who has qualifications behind them. Do not get your information from TikTok or Instagram. And then once you've got your information, so once you know your risk, how it all plays into you, you've made some changes to your lifestyle, you're on the treatment that works for you, then just go and live. Enjoy your time. Don't spend all this time worried about doing the right thing. What's the latest fad in, how to get the protein in and all that sort of stuff. Because I love women to live well. Absolutely. I want everyone to be eating all their protein, getting their sleep, doing their breath work. All of that is so important. But also, if that's all you're focusing on, then you're missing life. So we just want to simplify it, get into change a few things, make sure that you're feeling well, and then not doing things that are bad for you, and then go and live.
That's a wonderful way to end it. Thank you very much, Dr. Sarah Farrell. I wish you all the best. I think you're fighting a wonderful crusade, and I hope it just gets better and better for you.
Well, thanks so much, Patrick.